Okay, let's unpack this. Imagine the human body, right? Not just, organs and stuff, but like a really complex, well-engineered building. Over time, even the best foundations, the strongest structures, they start to show a bit of wear. But for you as a future medical professional, understanding that wear and tear, well, it isn't just about creaky joints, it's really about spotting these crucial changes that genuinely impact quality of life and even, survival.
Precisely. Today we're embarking on a deep dive into the clinical effects of the aging musculoskeletal system, the MSK system as we call it. We've gathered some key insights from researchers like Dr. Shailesh Kamble and others, and our mission really is to boil this down into powerful, usable knowledge for you. The goal is for you to leave with a solid framework for understanding, diagnosing, and ultimately managing these extremely common conditions.
Yeah, think of it like getting a bit of a shortcut to being properly informed about conditions you'll definitely see. Things like osteoporosis, osteoarthritis, sarcopenia. We'll dig into why they're so common now, what they actually look like in patients, and crucially, what we can actually do about them. And this is where it gets really interesting, I think. As you get better at spotting these changes, you'll be much better placed to support your patients as they age. So, to kick us off, here's something to mull over. A little thought experiment. Imagine two patients, both in their 70s, both fall. One gets maybe a minor bruise, nothing serious. The other fractures their hip. What's the fundamental difference there between what we might call normal aging and this fragility fracture? We'll circle back to that answer a bit later in our deep dive.
Okay, first, let's just set the stage. The sheer scale of the demographic shift that's happening globally, it's pretty staggering. The population aged 60 or over
Yeah.
globally. It's projected to hit 2.1 billion by 2050. Now, it's not just a number on a page. It represents a really profound change in the patient population you'll be serving. It puts MSK health right at the front.
Absolutely. And it's not some distant trend either. Right here in the UK, the Office of National Statistics, they reported back in 2022 there were 12.7 million people aged 65 or over. That's a massive jump from 7.5 million back in 1972. And this aging population means these musculoskeletal conditions are just, well, they're everywhere, affecting over 20 million people in the UK. Actually, for people over 50, bone and joint diseases make up half of all chronic conditions. Half. So biologically, what's actually going on with the body's architecture here?
Fundamentally, aging. It represents this sort of progressive loss of physiological integrity. That leads eventually to functional impairment. It's basically the buildup of damage, molecular and cellular damage, over time. But what's really crucial to grasp is that the NSK system doesn't exist in isolation. It's deeply connected with the immune system, the brain, the endocrine system, nutrition, everything. You need that holistic view. It's absolutely essential for good patient care. Specifically for the MSK system, though, these changes show up as sarcopenia. That's the age-related loss of muscle mass and strength, and also a general decrease in bone mineral density.
Right. Yeah. And the clinical impact of those changes is huge. We're talking significant loss of muscle and bone strength, a much, much higher risk of falls and fractures, and a really big hit to someone's ability to do their activities of daily living, ADLs we call them. Basic things like bathing, dressing, making food. These aren't just minor issues. They directly undermine independence, dignity, quality of life. Your vigilance here as a future clinician can make a massive difference. Okay, let's zoom in now on one of the most critical issues, osteoporosis. Imagine your bones are like a really strong honeycomb structure inside, intricate, supportive. With osteoporosis, that honeycomb starts to lose its density. The connections thin out, the whole structure becomes incredibly fragile. Our sources describe it as a systemic skeletal disease, low bone mass and this microarchitectural deterioration.
Exactly. And that fragility comes from increased bone turnover. Basically, the process of bone resorption, that's the natural breakdown of old bone, starts to outpace bone formation, the building of new bone. A key example, a major driver, is estrogen deficiency, especially after menopause in women. This imbalance leads directly to fragility fractures. The WHO defines these as fractures from forces that wouldn't normally cause one, basically a fall from standing height or less. So going back to our opening question, the patient who fractured their hip from a simple fall, that was likely a fragility fracture. It signals underlying osteoporosis.
Oh, okay.
The key difference wasn't the fall itself, but the bone's underlying strength, or lack of it.
That estrogen link is really powerful, isn't it? Especially thinking about bone density. It explains a lot about why the stats show women are hit so much harder by osteoporosis. In England and Wales, something like 2 million women have it, and the prevalence just skyrockets with age, maybe 2% at 50, but over 25% by the time they're 80. And globally, these aren't rare things. Around 180,000 osteoporosis-related symptomatic fractures every year, just in England and Wales. So what's the specific mechanism? How does estrogen play such a big role in this bone loss?
Well, the sharp drop in circulating estrogen that happens around menopause, usually starting around 50, 55, that's a major accelerator for bone loss in women. Estrogen is critical for maintaining bone density. When it drops off, the balance tips heavily towards resorption, towards breakdown. And the consequences of these fragility fractures, they're severe. Hip fractures, for example, have a really high mortality rate, up to 20% within a year. And significant morbidity, too. Things like pulmonary embolism, PE, that's a clot in the lung DVT, deep vein thrombosis, chest infections, even vertebral fractures, the ones in the spine, which can sometimes be silent. Maybe just showing up as height loss or a stooped posture. Even they carry a 4.4 times increased mortality risk, plus chronic pain, breathing problems, GI issues. It's serious stuff.
So thinking as clinicians, what are the absolute key risk factors for osteoporosis we need to have on our radar? The sources break them down, but I guess the real skill is seeing how they interact.
Indeed. We often split them into non-modifiable factors, things you can't change, like age, being female, ethnicity. Caucasians tend to be more affected, having had a previous fracture or family history. Then you have the modifiable factors. These are where we can potentially intervene. Things like low bone mineral density itself. Drinking too much alcohol, more than 3.5 units a day, is the figure often cited. Low body weight, so a BMI under 20, smoking, and not being active enough. But then there's a whole host of medications and underlying conditions that bump up the risk too. Long-term steroids, some antidepressants, diabetes, rheumatoid arthritis, even things like proton pump inhibitors, PPIs for acid reflux.
Right.
The takeaway for you as a clinician is really to look at the whole picture, the cumulative risk.
Yeah.
It's often not just one thing, but several factors combined that really tell you who's vulnerable.
And for diagnosis, what's the definitive tool? How do we actually measure bone health?
The gold standard, the test we rely on, is the DEXA scan, dual energy X-ray absorptiometry. It's not just a standard X-ray. It uses two different low-dose energy beams to precisely measure bone mineral density, or BMD, usually at the hip and the lumbar spine. The results come back as a T-score. This basically tells you how many standard deviations of patient's BMD is below the average BMD of a healthy young adult at their peak bone mass. A T-score of negative 2.5 standard deviations or lower. That indicates osteoporosis. If they have that score and they've already had a fragility fracture, then it's classed as established or severe osteoporosis. A key clinical point here, though. The T-score is vital, yes, but a DEXA scan is just a snapshot in time. Your job is to interpret that snapshot within the patient's whole clinical context. Bone density is one piece, an important piece, but not the only predictor of fracture risk.
Okay, so it's not all just diagnosis and scary statistics. What can we actually do? What proactive steps can we encourage patients to take, and what are the main medication options?
Absolutely crucial are the lifestyle interventions. They really form the foundation of prevention and management. Regular weight-bearing exercise, things like brisk walking, jogging, maybe dancing, and muscle-strengthening activities, like resistance training with weights or bands, that's vital. Nutrition is equally key. Ensuring people get enough vitamin D, the general advice is 10 micrograms a day or 400 international units, plus enough dietary calcium and just a generally balanced diet. Then, on the medication side, our main players are the bisphosphonates. These are anti-resorptive agents. They basically slow down the cells that break down bone, and they promote mineralization. They help stabilize and sometimes even improve bone density.
Okay.
However, it's really important to be aware of potential side effects. Things like osteonecrosis of the jaw, though rare, and gastric ulcers or irritation. So patient counseling on how to take them correctly, upright with plenty of water, not lying down afterwards, that's absolutely critical. And always check the latest NICE guidelines for recommendations.
Right. Okay, let's pivot now to our second big condition, osteoarthritis, or OA. If bones are the frame, maybe cartilage is like the smooth, low-friction surface, the shock absorber in our joints, allows everything to glide. With OA, this cartilage starts to get damaged, it things out in patches. This leads to the bone underneath remodeling, and you get these bony growths at the edges of the joint, osteophytes. It's incredibly common. The sources suggest eventually pretty much everyone gets it to some degree. 80% of over 80s are affected. That's about 10 million people in the UK.
Yeah, the clinical features are often quite familiar. Patients usually complain of pain, stiffness, sometimes joint deformity, maybe some swelling. One thing that helps distinguish OA stiffness is that it's typically short-lived, often worse after rest, but usually ease off within about 30 minutes of getting moving. That's different from inflammatory arthritis like rheumatoid arthritis, RA, where morning stiffness can last for hours.
Oh, okay.
You might also see specific bony lumps in the hands of Heberden's nodes. Those are in the joints nearest the fingertips, the DIP joints, and Bouchard's nodes in the middle joints, the PIP joints. Those are good clinical clues.
Okay, here's a quick clinical thinking point for you. Imagine you're looking at an X-ray of an older patient's knee. They've been complaining about pain and stiffness. What specific signs on that X-ray image would make you think, this looks like osteoarthritis? We'll check back on the answer in a moment.
Okay, so radiologically, the classic signs of OA that you'd be looking for on that X-ray are: first, loss of joint space. The gap between the bones narrows as the cartilage wears away. Second, the presence of those bony spurs we mentioned, the osteophytes. Third, subchondral sclerosis. That's where the bone just beneath the cartilage becomes denser, looks whiter on the X-ray. And fourth, sometimes you see subchondral cysts, little fluid-filled holes in the bone beneath the cartilage. These are the visual confirmations of that cartilage breakdown and bone reaction. As the cartilage wears away completely, the bone underneath can become exposed and look really smooth and polished. We call that eburnation.
And when it comes to actually treating OA, we have non-operative options and surgical ones. What are the mainstays of each?
Right, the non-operative strategies are always the first line. They focus on things like weight loss, if appropriate, which can significantly reduce load on weight-bearing joints like knees and hips. Also, exercise tailored to the patient physiotherapy is key here. Managing pain with analgesia like paracetamol or NSAIDs, non-steroidal anti-inflammatory drugs, though you have to be careful with NSAIDs long-term. And sometimes joint injections like corticosteroids can provide temporary relief. If these conservative measures just aren't cutting it anymore and the pain and functional limitation are severe, then operative interventions come into play. Joint replacement, particularly hip and knee replacements, can be incredibly effective. They offer dramatic pain relief, improve joint function, range of motion, and really boost mobility, helping people get back to work, hobbies, just living their life.
But while joint replacements can be life-changing, it's crucial, isn't it, for us as future clinicians to know the potential downsides, the complications?
Absolutely essential. Complications can be systemic, affecting the whole body, like urinary tract infections,
Right.
UTIs, chest infections, blood clots like DVT or PE, or they can be local, related to the surgery site itself. Things like difference in leg length afterwards, dislocation of the new joint, infection deep around the implant, loosening of the implant over time, what we call aseptic loosening, which might require revision surgery years down the line, and potentially damage to nearby nerves or blood vessels during the operation, like the sciatic or femoral nerve. Understanding these risks is just part of providing good, informed patient care and managing expectations.
Okay, moving on to our third big challenge area, sarcopenia and frailty. So if bones are the structure, joints the hinges, then muscles. Muscles are the engine, the power that moves everything. Back in 1989, Erwin Rosenberg coined the term sarcopenia. It's from the Greek. Sarx meaning flesh and penia meaning loss. It describes this progressive age-related decline in muscle mass and strength. It's a syndrome, really, that increases the risk of physical disability, poorer quality of life, and even death.
Yeah, for diagnosis, the European Working Group on Sarcopenia in older people, they have specific criteria. It involves having low muscle mass, plus either low muscle strength or low physical performance. You need both components. You see, muscle homeostasis, keeping muscle healthy, it's a really delicate balance. It involves new cell formation, muscle growth, hypertrophy, and protein breakdown. It's coordinated by loads of different systems, neurological, endocrine, immune, and heavily influenced by nutrition and activity levels. When that balance gets upset, particularly by those systemic factors, sarcopenia can really accelerate, leading to quite a dramatic loss of function.
Right. Now, here's a quick question to file away, because you might hear these terms used, maybe even interchangeably sometimes, but they are different. What's the actual distinction between sarcopenia and cachexia? We'll clear that up in a sec. But first, let's talk about frailty. Our sources define frailty not simply as being disabled, but as a distinct medical syndrome. It's characterized by diminished strength, reduced endurance, and lower physiological function overall. And this makes an individual really vulnerable. Even a minor stressor, like a mild infection, can cause a significant decline in function.
And crucially, frailty isn't necessarily a one-way street. It can be reversible, or at least slowed down or attenuated, with the right interventions. This makes early detection by all health workers, including you, absolutely vital. Mandatory, really, because frailty is a huge risk factor for ending up in hospital, needing institutional care, becoming disabled. It's an independent predictor of morbidity and mortality in hospital patients. The typical picture, the phenotype of frailty, often includes reduced mobility, changes in posture and gait related to the MSK system, and also neurological issues affecting gait and proprioception, that sense of where your body is in space. All of this contributes to that increased risk of falls and fractures we keep coming back to.
Okay, so back to that question. Sarcopenia versus cachexia, what's the difference?
Right. So sarcopenia is specifically the age-related loss of muscle mass and function. It's considered a more intrinsic part of the aging process itself. Cachexia, on the other hand, is a more complex metabolic syndrome associated with an underlying illness. Think cancer, chronic heart failure, kidney disease, COPD. It involves involuntary weight loss, yes, but it includes loss of both muscle and fat mass, and it's often driven by inflammation related to that underlying disease. They can definitely coexist, which complicates things, but their primary drivers are different.
Got it. So knowing frailty can potentially be reversed or managed, what are the key interventions?
Well, the interventions for frailty really overlaps significantly with those for sarcopenia and even osteoporosis. It's about a holistic approach. Targeted exercise programs are key resistance training, balance exercises. Comprehensive nutritional support is vital, ensuring enough calories, enough protein, checking vitamin levels, especially vitamin D, and a really important one, reducing polypharmacy. That's when patients are on multiple medications, often unnecessarily. We use specific tools for this, like the STOPP and START criteria. STOPP stands for Screening Tool of Older Person's Prescriptions, helps identify potentially inappropriate meds. START is the screening tool to alert doctors to write. Treatment helps identify meds that should be prescribed but are missing. Optimizing medication is crucial. And this holistic approach is exactly why caring for older adults really needs a multidisciplinary team, an MDT. Geriatricians, dietitians, physios, occupational therapists, and critically, you as a future clinician. The results speak for themselves. Orthogeriatric services, where geriatricians work closely with orthopedic teams, they've dramatically cut 30-day mortality from hip fractures, from around 13% down to 7%. That shows the power of coordinated, specialized care.
So let's wrap this up. What's the big picture takeaway for your future practice? Today, we've kind of navigated this really complex territory of the aging musculoskeletal system. We've looked at the invisible thief of osteoporosis, the worn-out hinges of osteoarthritis, and the sort of fading engine of sarcopenia and frailty. We've seen how interconnected they all are, how to spot them, and why early intervention and teamwork are just so critical.
Indeed. And with the older population growing so rapidly, you will encounter these conditions frequently. It's unavoidable. Your ability to really understand the mechanisms behind them, to recognize the risk factors early, and to initiate the right interventions, whether that's lifestyle advice, medication, or knowing when to refer for surgery that will directly shape your patient's quality of life, their independence, their longevity. Hopefully, this deep dive has given you a solid foundational framework to build on.
And remember that X-ray question about OA. The key signs you'd look for are that loss of joint space, the osteophytes or bony spurs, the subchondral sclerosis, that whitening under the cartilage, and maybe subchondral cysts. Spotting those is key. And also, remember our bigger question. Can frailty really be turned around? The evidence suggests, yes, it can be reversible or at least significantly attenuated with the right targeted interventions. That's a really powerful and I think hopeful message for you to take into your clinical work. It really highlights the positive difference you can make.
My final thought for you is this. Try not to view the aging MSK system as just a list of separate problems. See it as a dynamic, interconnected interplay of changes happening over time. As future medical professionals, your job isn't just to understand this complex dance, but importantly, to help choreograph the interventions. Interventions that help maintain independence, preserve dignity, and really enhance the quality of life for your older patients. It's not just about adding years to life, it's about adding life to those years.
Thank you so much for joining us on this deep dive. Keep asking those questions, keep exploring the why, and definitely stay curious.